All right, well, thanks everyone for joining today. The name of today's topic is Healthcare Payers 101, How to Follow the Money, and I will be your host, Matthew Yoder. So I'm qualified, quote unquote, to give this presentation because 3 years prior to matriculating to medical school, I was a healthcare management consultant with a small consultancy in Chicago named REIT, and we would work for a whole host of clients within the healthcare industry, mainly payers. And so that was ranging anywhere from managed care organizations, which take care of managing the Medicaid population, all the way through to the commercial insurance that I'm sure most people on this call are familiar with. So the topic today is going to really focus in on the system and also what technology is embedded within that system in terms of how providers ultimately do get paid. Now, this is kind of a broader definition of technology, I will admit, but I believe it's still relevant to every single person in the healthcare field. So without further ado, let's get into it. So the agenda for today, I'm going to give a quick introduction, very basic, about how the money flows and information as well. And then I'll go through a couple definitions. If at any point I say an acronym or a word that no one is familiar with, just raise your hand in the chat, or feel free to speak up and I'd be happy to clarify. And then I'll talk about what some of the payers are that exist in the United States and kind of how the different populations they cover would then, they would need to perform different functions, even though they're still operating within the same umbrella of the healthcare system. And then I'll talk about the information flow, and that's really where the technology piece of this talk comes into play, and how, what it looked like in the past, what it moved to currently, and then what some of the potential future technologies are about to be implemented. And then I'll walk through some of the types of payments that you'll see in terms of the contracts that are signed between payers and providers. And then lastly, I'll talk about the impact that the system has on providers. So I'll start first with an introduction, like caveat. Of course, this is within the United States. That's my experience. That's what I know. And that's what I imagine most people will be practicing under as well. So how do providers ultimately get paid? Well, as patients, I'm sure our earliest exposure to the healthcare field was going to the providers. And so when we would go to see a doctor or anything like that, we would just go, and our parents really took care of most of that. But I'm sure as most of us grew up, we realized that we need health insurance and that there are other avenues that we can go through in order to seek care and not worry about all the financial aspects immediately. And so that's where payers come into play. Payers are synonymous with health insurance companies, and they can act as the financial representative, and they also can act on behalf of patients in terms of having that expertise. And so a patient might not understand how much a procedure is supposed to cost, or they might not have enough cash on hand in order to pay for an entire procedure all at once. And so that's where the payers come into play. And they also can provide a little bit of checks and balance on providers. But you can see that I've highlighted here this information, and that's ultimately what needs to be exchanged in order for the money to flow. And so I've got the big pathway here, how patients pay their premiums and their deductibles probably are up here and co-payments, but that goes to the payers, and the payers go to the providers when the providers render their services. There is still, of course, opportunity for patients to pay directly to their providers. And I think Sidecar Health is an interesting example of that happening in the marketplace, but I won't get too much into that. You can review that company on your own if you're interested. So as long as there are no questions on this slide and everyone understands the basic flow of money following information, I'll talk through some of the definitions that are going to be important throughout this discussion. So what are we talking about here? What is a provider? Well, a provider is any licensed professional providing care for a patient. A lot of times we think of providers as big institutions like Wexner or any other, just like a provider group, something like that, or One Orthopedics. But a provider can be anything that provides care for a patient. It could even be if you have a loved one with a disability and you are providing care for them. I forget what the exact requirement is, but if you're dedicating a substantial amount of time, you can become a provider. So it's a much broader definition than many people consider. And then what is a payer? Well, a payer, like I said earlier, it's synonymous with an insurance company. And so it's an entity operating on behalf of the patient to pay for that healthcare. And so when I talk about information that's being exchanged between providers and payers, and that information that ultimately came from the patient in the first place, I'm talking about some of the things that are listed here. This is not an exhaustive list, but these are required, among other things. Yeah.
I'm not sure your slides are showing on the share screen. I'm just getting the intro slide here.
Oh, weird. All right, I'm going to stop and I'm going to try it again. Is it sharing now?
Okay, now it looks correct. I don't know if it was frozen. Go ahead.
Okay, perfect. All right, so I was talking about some of the payment information, and this is included on a healthcare claim. And so you'll hear me talk about claims. It's the same for any sort of insurance provider. If you file a claim, it's because some services were rendered that you had insured through this entity, namely the provider. And so in order to be paid for that, a provider on behalf of the patient then would submit that healthcare claim that is derived from the encounter. And then it must include certain information like the tax identification number, the diagnosis code, common procedural terminology. And a lot of this shows up for providers within the electronic medical record. And that's why it's so important to have correct documentation. And I address this later on in the talk. But this is kind of where that overlaps and where the providers are held accountable for appropriate documentation in order to receive remuneration for the appropriate services that they've rendered. And of course, I have highlighted here patient information that needs to be included on the claim, because you need to make sure that you're performing not only someone who's insured, but the right person. And so sharing that information is of course under lock and key. And so payers are also held to the same high standards of HIPAA and accountability that providers are. And then I'll address some of the contractual terms that can go on, and stuff like place of service or length of stay. That becomes very important when we talk about was it an institutional claim versus a professional claim. And I won't get too into the weeds on that, but just know that there's a difference depending on the place of service. So if you're in a hospital, in an institution, you're going to submit a different claim type to a payer, as opposed to if you're in an outpatient facility or an ambulatory surgical center, that's going to be a different form. And so people can sometimes get in trouble if they don't know that. A lot of this is taken care of by administration, but it's good for any healthcare professional to also understand the mechanisms that are involved. And so I used the term encounter earlier. Also just wanted to clarify what that means. It's any time a patient connects with a provider. And so there are billable encounters and there are non-billable encounters. And that's really what administration cares a lot about. But you can see a patient and not bill for that. It could be a routine follow-up that's included in a case rate, or it can be a billable encounter that's just a routine checkup. And then that claim is what I talked about. That's kind of that the bridge between a provider and a payer is this claim. And similarly to the medical record, that is kind of what's written in stone in terms of, okay, here are the services that were rendered, here's who the procedures were done for or on, and ultimately who was involved in the care and who should be paid for these services. And so it's a digital or physical receipt of services rendered by the provider. I believe with the onset of the electronic medical record, we're somewhere near 97% of all health claims, health insurance claims rather, are submitted digitally, but there still needs to be a mechanism for the physical receipts in order to, if that's not set up for providers to still be paid for their services through physical receipts. And that was a big technological advance, of course, when you no longer need to mail these and then write a check and send it back. The more and more we can create a digital interface. And that's kind of the vanguard also of the next stage that I'll talk about. But that was a key component to the technological advances within the software and the interface between providers and payers in order to be paid. And then lastly, an explanation of benefits. I'm talking mainly about these, the payers and the providers duking it out for payment. But of course, an explanation of benefits then needs to be sent to the patient. And I'm sure most of us are familiar with this. We've received one before if we've ever received care. And that's just a copy of the covered services from the claim sent to the patient. We'll talk about any of the co-payments or any residual payment that needs to be made for uncovered services. Are there any questions so far before I dive into the next part of the talk? I'm making room for silence, but I think silence means keep moving. So I will. Oh, I see something. No questions yet. Perfect. All right. So payers, who are they and why are they important? Like I mentioned before, payers is synonymous with health insurance companies. But I would like to distinguish between some of the types of payers that we might encounter as physicians or as healthcare professionals. There's commercial, which most of us are probably familiar with, and anyone who's employed is usually part of this commercial payer. And so that's kind of like your United Healthcare or your Blue Cross Blue Shield, Aetna. These are these big players that commonly work with an insurance broker to then go and sell their insurance, their health insurance to employers. And so a majority of citizens in the United States are insured through a commercial insurance plan. And then there's also marketplace, which is a recent development in the marketplace. It was set up through the Affordable Care Act, and that allows for those same, it can allow for the same commercial health insurance companies, but also others to enter that market and compete with the government in order to provide care for someone who's unemployed or students also. And then lastly, we've got the government, which I'm sure some of you are familiar with how the government insures, but it could be a bit of a roundabout way. The best way to think about it in terms of this talk is that covering a certain population, such as those who are socioeconomically disadvantaged, like in Medicaid, or 65 plus on Medicare, if they are veteran status, or if Native American, then they all will fall under the umbrella of government services. And so why are these important? Well, they're important because you can then insure populations as opposed to everyone fending for themselves. You're able to cover a population that might be at risk, like the Medicaid population or the Medicare population. And you can also garner a lot more insights in terms of data analytics if you cover a lot of 65 plus year olds, as opposed to maybe a clinic that sees a wide range of ages. You're able to then kind of tease out some of the trends that you might see in healthcare. Additionally, they serve as representatives for patients. So not every single patient is that savvy in terms of how much a syringe should cost, or just how to navigate the whole healthcare system. And so they can serve as representatives both from a financial standpoint and also in terms of care coordination. And then lastly, they connect providers into a network. So I'm sure we've heard terms like HMO or PPO, and that really talks about the network that's involved with connecting providers that might not necessarily be under the same umbrella for an institution on the provider side, but you can be within the same network. And so if you go skiing out in Colorado, you break your leg, you're part of a PPO, and you're within the same network as that, as your insurer, then you can go get care and it's covered, as opposed to if you beat the state or you need to negotiate right there in the moment with a broken leg. It's probably just not the best scenario. So those are some of the reasons why it's important. They're important, and I'm sure we can all think of pros and cons for having payers within the healthcare system. But here's some of the reasons why we've seen, or at least I've seen them play out within the market. So here's kind of the meat and potatoes of this talk: is how does the information flow from the patient to then the provider, to then the payer, and ultimately back to the patient. And you can see over in the top right corner, I kind of have this flow of the cycle, excuse me, of how information needs to be transferred from the patient. And then you go to have an encounter with a provider. The provider will then submit a claim, and then that claim would be paid out, and an explanation of benefits would go to the patient. And that's kind of the core cycle here. So we talk about how information needs to be exchanged and the software that's now involved. I mean, beforehand, this used to be all done on paper or word of mouth. You go and then you keep a record. Now, of course, that record is digital. And so alongside with the marketplace, you have a whole cornucopia of options in order to buy insurance, and you can go on the internet and find pretty much anything you want in terms of being covered. But when we talk about this cycle here, prior to the encounter, some information needs to be exchanged. And so the provider will schedule an encounter with a patient, and then the patient will provide the insurance information. And then the provider will work with a clearinghouse or with the payer directly to confirm that insurance status. And so once that's confirmed, that facilitates an easier exchange at the actual provider site. So the encounter can flow smoothly. You understand what needs to be documented, what's covered. You could even talk through that with the patient if they showed up and it was like, okay, I know that these certain procedures will be covered under your insurance, but these will not. So that can also be included in the aspect of care delivery of, do you feel comfortable taking on this financial hit right now? Or would you prefer to do a different type of procedure? And then from there, once the encounter has happened, and the encounter then becomes a claim. And this is where the rubber hits the road for a lot of providers. And as residents, this is going to be very key as well, because most residencies are within teaching hospitals, and you're going to be just steeped in the electronic. I have Medicare here. Obviously, this is supposed to be medical record. My apologies. I'll correct that later. But you should be familiar with these by now: Epic, IHIS, Cerner. And then this, of course, needs to interface with the payer system. And I have an example here, Oracle, which is kind of the cloud computing next level of claims processing software. But they need to be able to interface in order to link up those diagnosis codes that I talked about and the common procedural terminology, and make sense of the contract that was signed, what logic then flows within the software in order to then assign a dollars and cents figure for either the case rate. And I talk about these in the next slide, so I won't get too involved here, but for whatever services were rendered, there is a specific price attributed to them. And so that's important right here on the providers to get that right and make sure that also it's appropriate level of care. You have to attach the right diagnosis code to the right procedure to make sure that it was an appropriate procedure to do for the clinical presentation. And then lastly, once that claim gets paid out, we have the EOB, or the explanation of benefits. And then that's internal to the payer. They've got a software that calculates what can be paid out and what ultimately might need to be paid by the patient, any remainder, or to just calculate how much of their deductible has been hit. And it will also apply clinical and payment policies to the claim in order to calculate what the contracted rate for covered services are. I won't get too much into clinical and payment policies right now, because that's maybe a healthcare payer 102 topic, but just suffice it to say there are certain standards of care or certain maybe limits of durable medical equipment that when the system sees that, it can trigger a warning or a response, and it might get kicked over to a doctor that works for the health insurance company, and the doctor will then sign off, yes, this is an appropriate level of care, or it's okay to go past this limit for this specific patient. And like I talked earlier about some of the recent innovations, that includes moving to the cloud for processing, like Oracle. They're a big player in that space. And not only processing, but also sharing information. Like I mentioned with the clearing houses, if you can immediately transfer information about a patient, that's of course hugely beneficial, especially if it's time sensitive, if you want to know whether or not you should submit to surgery now or not. And this is a bit of buzzword. I will be honest, I don't believe that anyone is using blockchain right now for any sort of claims processing. And the biggest concern there is privacy. It would need to be a private blockchain. And a lot of the benefit that blockchain gives is kind of like that accessibility. Of course, also it's an immutable record, which is good too. So I think that that could be useful in the future. But right now, the mechanism of application for that is just kind of stalled out. But who knows? And then on to the next one. So here's how we're doing on time. Okay, we don't have a lot of time, so I'm not going to talk too much about this. These are the different contracts you can sign or different ways in which you can be paid as a provider. And so fee for service, that's just like a one-to-one transaction. I perform this procedure, and according to the physician fee schedule, it costs this amount of money. You can Google the physician fee schedule if you're not familiar with what I'm talking about, and you can see that there are dollars and cents associated with specific codes. Or you can have a case right there, which is if I do a knee replacement, then it's going to cost X thousand dollars. There's also capitation, which is you sign up to cover a certain population, or that could be regionally, that could be a pediatric population. You could cut it up however you want to, and you negotiate that with the payer. And you can have upside risk, which is where we'll pay you X amount of dollars a month per member. And then anything that you spend less than that in providing care, then we will split the profits with you 40, 60, or whatever you ultimately are able to negotiate. And then that's kind of like the foot in the door. And then the downside risk is, okay, if you overspend, then we have to also split the losses. And then I also want to touch very briefly on administrative services only. There's kind of a trend also in healthcare that's going on where companies who have maybe large groups of employees, they find that they are able to keep a pool of money in order to pay for those claims, but they still want to have the network, and they still want to have kind of the expertise that comes along with negotiating healthcare claims from the health insurance company. And so they will just use the administrative services as opposed to the whole services that are available to them through the health insurance, namely paying the claim. So you wouldn't pay a premium or anything like that, but you would pay out all of the claims for your employees. Does that make sense? And I've got this little question here to jog some thought. What is incentivized with each of these different payment structures? I won't get into it too much unless you would like me to, but maybe think through if you were, or when you're a physician working under a fee for service, are you more likely to do that next procedure, or maybe do that more, maybe not consciously, but subconsciously, maybe you're more incentivized to do one thing over the other. And so lastly, why does this matter? What's the point here? Well, ultimately, this is how providers get paid. So it's important for that aspect of keeping a living, and maintaining a living. Of course, patients come first, but this is a great way to incentivize making sure that you appropriately document everything that was done for the patient. And then you get a second set of eyes as well on it, with payers coming through and scrutinizing and saying, oh, okay, that's what was done. Here's why it was necessary. Here's how much the patient should be charged for it. And then lastly, I've got the citation down there too, but physicians spend about 8 to 9 hours a week on administrative tasks. So if you understand why you're doing it, you might be less likely to burn out on having to document every single time that, okay, this diagnosis code goes with this, and why am I even doing this? And now you have a better understanding of why all of this is important, and where the field is moving. So with that, I will close and ask if there are any questions.